everyone, and welcome to today's webcast, Pediatric Treatment Update. My name is Corinne Pettit, and I will be your moderator for today's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer's desktop in the upper right corner. You've joined the presentation listening using your computer speaker system by default. This means that if you can hear music through your computer, you should be able to hear the presentation. If you'd prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a new strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified. Number 1, accelerate discovery to cure psoriatic disease. Number 2, improve health outcomes. And number 3, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis to help manage your disease and to find others who understand what it means to live with psoriatic disease. You can help accelerate efforts toward the cure and greater understanding of psoriatic disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. The registry, which involves a network of dermatology clinics, collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can also share your experience with the researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientists. Answer questions and view your data along with thousands of other participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, you can visit the website listed on the screen after tonight's presentation. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigating insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or by visiting psoriasis.org/navigation center. And to achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. Now I'd like to introduce our speaker, Dr. Allison Small. Dr. Small is a board-certified dermatologist with fellowship training in pediatric dermatology. She is a member of the American Academy of Dermatology and the Society for Pediatric Dermatology and sees patients with a wide range of skin, hair, and nail disorders at OHSU's Center for Health and Healing, Dornbecker's Children's Hospital, and Randall's Children's Hospital in Portland, Oregon. She enjoys helping patients with common dermatologic conditions such as acne, eczema, rashes, birthmarks, and other lumps and bumps. She has particular interest in vascular anomalies and genetic skin disorders. She enjoys teaching and is lucky to have medical students, residents, and fellows working with her to learn and care for patients. Welcome, Dr. Small.
Thank you very much. Great. Good morning, everybody. Thank you to the NPF for inviting me to give this webinar, and thank you all for your interest in being here today. Just a few disclosures. I do not personally have any relevant financial relationships with any commercial interests, but a lot of these slides were originally developed by a couple of pediatric psoriasis experts, Kelly Cordero and Elaine Siegfried. Some of them have been modified or have added things for the purposes of today's talk, and these are their disclosures. So these are the things we're going to try to address today. So first of all, understanding how psoriasis presents in pediatric patients. I'd like you all to be able to be informed about newly approved biologic treatments and all the options that are available for patients under the age of 18. And then identifying risk factors and understanding which screenings are recommended for pediatric patients that have psoriatic disease. So first, let's just discuss what is psoriasis. So it's a chronic inflammatory skin disease that does have increasing recognized comorbidities, meaning other medical problems that have been associated with psoriasis. It is mediated by T cells, which are part of our immune system. They're white blood cells, and it can be triggered by environmental factors in patients that are susceptible. The immune responses then contribute to the inflammatory cascade that leads to the visible skin lesions that you see. So psoriasis affects more than 7 million Americans. 2 million have moderate to severe disease, and there's about 200,000 new cases per year overall, with a peak age of onset of 15 to 35 years of age. The pediatric psoriasis specifically, about a third will present before age 20, many even in infancy. The mean age of onset, so the average age of onset, is 2 to 10 years of age, but this can vary pretty widely depending on the type of psoriasis and which population you're looking at. More than 70% of kids that have psoriasis will have a positive family history, so someone else in their family has psoriasis as well. And then there's 40.8 per 100,000 new cases per year. That's the incidence, and the prevalence is 2.5%. So about, at any given time, about 2.5% of the population will have psoriasis. So how does psoriasis develop? Well, there is a genetic mediator of childhood psoriasis that's been identified. It's this HLA-CW6. This is also called the psoriasis susceptibility locus. But there are numerous genes that have been associated with psoriasis in patients, but this is one that particularly has been associated with childhood onset psoriasis. It's also mediated by immunologic cells and molecules. So there's particular lymphocytes, which lymphocytes are part of your immune system, and they're also known as white blood cells. There are different types of those, and these are the Th1, Th17, and Th22 types of lymphocytes have been associated or shown to be part of the pathway of developing psoriasis. And then there are multiple clinically recognized triggers that, again, in patients that have these pre-susceptible backgrounds, when exposed to these triggers, can develop what we see on the skin as psoriasis. So what are some of these triggers? So these triggers are more often reported in childhood psoriasis than in adult onset psoriasis. One of the most common is infections, so microbes, usually either perianal or pharyngeal strep, so strep throat, or kids can actually get strep infections around the anal area as well. But viral infections and other infections have also been triggers. Cutaneous trauma leads to something that we call kebnerization. Kebnerization basically just means that if you have a cut or scratch or scrape or something on the skin, that the psoriasis can show up in that area. So that inflammation from that trauma leads to psoriasis showing up there. Medications can trigger psoriasis. A lot of these aren't as commonly seen in pediatric populations, but sometimes they are. Anti-malarial medications, beta blockers, and then what we call corticosteroid withdrawal. So sometimes people will get steroids for a variety of things, and as people come off of that, it can really make their psoriasis flare. Stress is definitely a trigger, whether at home or school. Obesity, and we'll talk more about that. And then tobacco smoke, and that's even just secondhand smoke. So how do we define disease severity? Well, most commonly, we think about the body surface area, and that means what percentage of the skin overall has psoriasis on it. So mild disease being less than 3%, moderate 3 to 10%, and severe more than 10%. But that's not the only factor that we think about when we're deciding on the severity of psoriasis for a patient. Other factors that need to be considered is how red are these areas? Are they kind of a light pink, not that inflammatory? Are they really flaming bright red? How thick are they? How much scale is there and how much scale is sloughing? The distribution, so what parts of the body are involved and how old is the patient? The other things that really contribute to overall disease severity are quality of life. So what sort of physical impact does the patient have? Are they having a lot of pain because their hands and feet are involved and they're having trouble walking? Are they really itchy? Are they having trouble with just overall daily functions? Do they have a lot of flaking scale or odor that's really difficult for them? And then the emotional impact, the social impact, and then medical impact, again, as I mentioned, having other medical problems that might be associated with psoriasis. So there's a large spectrum of how you can see childhood psoriasis present, and the morphology means what it looks like, basically, and then the site of involvement, so where on the body. So the plaque type is the most common type that you'll see, and probably what most people are familiar with when they just think about psoriasis. That's the one that comes in larger areas, often is on the knees or the elbows, but we're going to go through a lot of pictures of these different types in just a moment. Guttate is the most commonly associated with strep infections, and these are smaller little spots that tend to be spread throughout the body. Inverse psoriasis, it tends to present in the diaper area, so that's a common presentation for infants or just anogenital in general, but also means involving the scalp, the ears, the underarms, the belly button. Nail psoriasis, we'll look at a few examples of that. Pustular psoriasis, which can be localized or generalized and very widespread, and erythrodermic, meaning you're red pretty much from head to toe. So these are examples of classic plaque psoriasis. So again, the knees and elbows, these pink to red plaques with this white to silvery scale. And then on the right, you obviously see a much more widespread distribution of this plaque psoriasis. So in children, the scale can often be less prominent than we see in adults, but it's still there, and otherwise they look very similar. So again, these pink to red, round, thick plaques with that kind of white silvery scale, just less of it. This is an example of annular psoriasis, which is a variation of plaque psoriasis in a sense, but it has that central clearing. So oftentimes it can look like ringworm and can be misdiagnosed as such for a long time, but it still has that same kind of scale at the edge there. And this is an example of that annular psoriasis, so ring-like psoriasis in infancy. So there's still some pinkness in the middle there, but definitely not as inflamed or scaly as the edges of the lesions. And these are two different examples of guttate psoriasis. So guttate psoriasis tends to be, each spot tends to be about less than a centimeter, and they can be very widespread, as you see on the left, lots and lots of spots, versus on the right, there's still several spots, but much fewer. And these are examples of inverse psoriasis. So on the left, you see a belly button that has psoriasis, and on the right is right inside the ear. And then palmoplantar psoriasis, psoriasis of the hands and feet, just different examples of severity. On the left, obviously, is much more red, more widespread on those areas. And then on the right, less confluent or not involving the entire area, but still involving both the hands and feet. Scalp psoriasis is very common. Again, it's sort of in that inverse psoriasis category. You can see focal areas of scaling and redness or really diffuse throughout the scalp. And then you can get, if you notice on the right-hand side, that really thick scale that can just be adherent to the hair and the scalp as well, that can just be throughout the scalp and can be really hard to get medications on. And then psoriatic alopecia, so that intense inflammation leading to loss of hair in those areas, which oftentimes just grows back once it's properly treated. And then facial involvement is really common in kids. These are just some examples of facial involvement. So talking about the overall clinical spectrum of how this presents in children, it might be influenced by age and gender. So they have found that nail involvement is more common in boys than in girls. Scalp involvement is more common in girls. And then the face and diaper area involvement is much more common in children than in adults in general. I mentioned the facial involvement. This is actually probably under-recognized or underappreciated. About a 38% of pediatric patients with psoriasis will have involvement of their face, 26 with either diaper rash or genital involvement. And then this Koebner distribution, so I mentioned before that Koebnerization means that there's some sort of trauma to the skin that then causes psoriasis to show up in that area. I'll show an example of this in a moment, but thumb sucking is a cause of that. Just having that recurrent trauma of the sucking can lead to flares of psoriasis on that area. Glossitis means inflammation of the tongue, and mucositis just means inflammation of other mucosal areas, so the mouth in general or the genital areas. So this is an example of that thumb sign. So this patient is likely a thumb sucker and causing flares with that recurrent trauma. These are examples of nail psoriasis. So on the top left, you can see just a few nails that are involved here, with the others being relatively spared. You can have this yellowing and thickening. Here there's a close-up example of what we call pitting, so these little spots within the nails. But you can see here that the nails are involved without any rash on the hands in both of these examples, versus this example, you have nail involvement as well as rash on the fingers, and that can happen either way. And this is a really severe and rare form of nail involvement, where you basically get pustules that develop underneath the nail and can cause the nail to lift off, but much more severe version of that nail involvement. This is called geographic tongue or benign migratory glossitis, and this can happen just on its own, but can also be seen in association with psoriasis. So you can see here these edges that show where there's actually loss of the normal surface of the tongue, and then that comes back and it can show a different pattern, so that's why it's called migratory, but that's one thing we can see in patients with psoriasis. And these are examples of severe generalized pustular psoriasis. So instead of that normal red with scaly plaques, you have pus right underneath the very surface of the skin. So now we've kind of gone through different ways that psoriasis can look and present, but how do we manage these? How do we manage patients, and what sorts of things do we think about? So we talked about the triggers, and those are always really important things for physicians to be considering and asking about and looking for, so that if we can identify those, we can avoid them or treat them. So if it's trauma related, we can sort of work through how to avoid those traumas to the skin. Infection related, if they've had ongoing strep infections, we can talk about treating the strep infection. If there's stress, talking about how to manage that and how to help children with that. And then medications or drug exposures, making sure that we've covered those things as well and are avoiding them if possible. And then looking for comorbidities, which we're going to talk more about a little bit later. It's really important to work with the primary care physician to screen for these, and then individualized screening based on each patient's individual need. So the main focus of today is to talk about new treatment updates. So this is just a kind of old look at how a lot of psoriasis treatments were approached. So starting pretty much always with topical therapy, moving to phototherapy, and then systemic medications, and using this stepwise approach. But really today, it's much more of what we call a multimodal therapy approach. So we have all of these options available to us, and oftentimes we're using more than one of them. And it really just depends on each patient's individual situation as to which one might be picked. So a lot of times it's this combination of topical medicines, phototherapy, biologics, lifestyle modification, trigger avoidance, all of these things together, as opposed to just this stepwise ladder. So briefly, I'm not going to talk a lot about topical therapies today, as these are a lot older treatments, but any of you that have had psoriasis or are newly diagnosed probably have had these medications prescribed before. So the things that we tend to use are just generalized emollients, so keeping the skin moisturized. Topical steroids are really the mainstay of topical treatment in psoriasis. There's a wide range of mild topical steroids to much more potent topical steroids that are sometimes needed. The topical calcineurin inhibitors include Elidel and Protopic. These can work really, really well in psoriasis as well. They are more, as far as effectiveness, if you have a really thick plaque, might not be as effective for that initial presentation, but are great to use for the face or the genital area and somewhere where that we don't want to use steroids long term. I know there's some questions about the safety of those medications, but the topical medications are safe when used properly, and how it has been between you and your physician and how they've explained to use them. So following those instructions is important, but they are safe to use and are definitely good options for certain areas, and to switch between using topical steroids or something that's not a steroid. The topical vitamin D analogs can also have that option, also known as calcipotriene. So oftentimes, again, we might start with topical steroids to calm down initial inflammation, and then as patients need to get to a more maintenance program, have medications that they're changing between, including the vitamin D analogs, calcineurin inhibitors, and steroids. And then kind of a more old school but often still used medication or treatment is coal tar or LCD. So phototherapy, I'll only briefly talk about this, but can also be a great reliable option for treatment. It is often a gateway to systemic therapy in children, and we use it for kind of more widespread disease. It can be great for guttate psoriasis when you have all those little spots and it's hard to get the medication on there. The downsides to phototherapy include that it's time consuming. So often you're having to go to a phototherapy center 2 or 3 times a week. It can be a pretty high expense cost and is not always easily covered by insurance. There's usually 2 phases. So you have the clearance phase, which again is usually 2 or 3 times a week for about 3 months at minimum. And then maintenance phase, where maybe you're going less often, but still trying to maintain the benefits that you've had. We usually use narrowband UVB. It's a very small area of UVB and has been shown to be safe. Outdoor sun exposure can be really helpful, is readily available, obviously free, but it's less predictable. We can't really prevent burning the same way. Higher risk of skin cancer using just outdoor sun exposure, but can be an option when people don't have the ability to get to a phototherapy center. So this study looked at the general prescribing practices between dermatologists and other physicians for children with psoriasis. And ultimately that they found that children are just undertreated. So I'll just point out some of these. So here's topical steroids, very commonly prescribed as we talked about, and have been increasing over time. Other topical medications, so the calcineurin inhibitors, vitamin D analogs, also increasing over time. Over-the-counters seem to be dropping as we've had more of these medications available to us. But biologics and other systemic medications have stayed pretty underused in children. And why is this? So in the past 20 years, less than 1% of children have been treated with these immunomodulatory therapies. And usually this is because there are concerns about short and long-term safety. And a lot of that's because we don't have the data in pediatric patients. So a lot of the initial studies are always done in adults, and it takes a lot more time to get those studies to children and to have the safety data available. And until we have that, it's usually not FDA approved, so that's the labeling part of it. They do require frequent lab monitoring, which depending on the age of the child can be challenging. And then they're very expensive, so getting them covered by insurance can often be a challenge as well. So this is just looking at our kind of more traditional systemic medications versus the kind of new biologic medications. So what does a systemic medication mean? Well, it's something you take by mouth that can affect the overall immune system and ultimately try to treat the psoriasis. Some of these more traditional medications include methotrexate, cyclosporin, or retinoids, commonly acitretin. And these are medications that have been around a long time. They have been proven to be helpful. They're established conventional medications, but they are not technically FDA approved for the use of in children with psoriasis. However, with that being said, they're some of the most commonly used medications when systemics are needed, and dermatologists in general are very comfortable with using these in children. Now, the biologics are the new novel contemporary medications that really target specific parts of the pathway that leads to psoriasis. So the more traditional ones kind of are this more widespread immunosuppression. It's not targeted. They can be used for a variety of inflammatory conditions, whereas these new modern targeted drugs are very specific to certain parts of the inflammation pathways that we know are active in psoriasis. So we have a lot of options, and it is a new and exciting era with a lot of new medications coming out as there's more and more research available about psoriasis. So what options are now approved for the use in pediatric psoriasis? So in 2016, etanercept or Enbrel was approved for the treatment of psoriasis in patients 4 years of age and older. And in 2017, just last year, ustekinumab or Stelara was approved for the use in patients aged 12 years of age and older with psoriasis or psoriatic arthritis. So how does this compare? And on the right side of this table, the EMA is the European Medical Association, and that just shows where we compare with what medications they have available. So they also have etanercept available, but for 6 years and up, and Stelara is the same. They have also adalimumab or Humira that is approved, which we do not yet have approved for pediatric use in the US yet. And then this is just a list of other biologic medications and small molecule medications that are used a lot in adults, but are also not approved for pediatric psoriasis at this time. So, but we do have two, which is exciting and new for pediatrics in general. So let's talk about these a little bit more. So as I mentioned, etanercept is also called Enbrel. It's approved for patients 4 years of age and older. This medication is a TNF inhibitor. So TNF stands for tumor necrosis factor, and it is an inflammatory molecule that is part of the psoriasis inflammatory cascade. It's seen in other inflammatory conditions as well. So it is specific to psoriasis, but not quite as specific as some of the other medications that are coming out and being developed over time. It is an injectable medication that's given once weekly. And these are just some pictures from the Enbrel website about a couple of the ways that you can inject the medicine. So there are just kind of old school syringes and needles that can be drawn up, but these are their kind of pre-drawn up syringes that are really easy to inject. So on the left-hand side with the purple, this is their SureClick auto injector, where that whole device is disposable. It has the medication in it. It has a push button on at the top of it that then puts the needle into the skin. The medication slowly injects, and you can see that through that yellow window. And then once it's injected, the needle will go up into the safety cap and the whole thing can be tossed out. And then on the right-hand side, this is their auto touch reusable auto injector. So the whole hand piece is something that you keep and is reusable. And then there are little cartridges that get put into it each time. And then that cartridge is similar to the other, where it has the needle and the medication in it. You push the button, it injects the medication. The cartridge itself is then able to be ejected and thrown out into a sharps container. And then the actual auto injector is reused for the next injection. So that's Enbrel as far as how to inject it and how often it's injected. But of course, the main question, as we talked about, is always what are the safety considerations? So there are a few contraindications, so reasons you can't start the medication. And those include active serious infection, a history of recurrent infections, heart failure, multiple sclerosis, or other neurologic demyelinating disease. So, and what side effects do we see? The most common are just injection site reactions, sinus infections, and headaches. So generally thought to be relatively mild. But of course, there are some potential serious side effects. And these mostly include infections, so that's the ones that we worry about. And that can include latent hepatitis B or tuberculosis. And what that means is if a patient has had hepatitis B or tuberculosis in the past, these infections can sort of just live within them. And then when their immune system is suppressed, they can reactivate and then cause a problem. So it's important that doctors are checking for the exposure to these things before these medicines are started. Nervous system problems, heart failure. Very interestingly, psoriasis, either new or worsening psoriasis, can be seen with the use of Enbrel. It tends to be a sort of rare paradoxical reaction, but can occur. Allergic reactions, and then immune reactions, lymphoma, other cancers, autoimmune hepatitis, or inflammation of the liver. And we'll talk briefly a little bit later about the true risks of cancers as well. And so the other approved biologic for pediatric psoriasis is ustekinumab, or Stelara. And this, again, is for 12 years of age and older. This one inhibits slightly more specifically molecules within the psoriasis pathway called IL-12 and IL-23. And these injections are initially done the first injection and then 4 weeks later. And then after that, it's only every 12 weeks. So a lot of patients like that option of how infrequent the injections are. They have a similar kind of auto injector that you can see here, where the medication is already in it, the needle's in it, just push the button and it injects. And then this was just an example of where these medications are injected. So the thighs are common. If you're having somebody help you, the upper arms, the buttocks, and then the lower abdomen are common injection sites. And that's true for pretty much all of these injectable medications. And what are some of the safety considerations for Stelara? So in the research that's been done, the safety profile in adolescents has been consistent with what was seen in the adult studies. The most common side effect being nasopharyngitis or sinus infections, upper respiratory infections, headache, fatigue. Again, as we talked about, the risk of infections in general because we're suppressing the immune system, either reactivation of an old infection or being more potentially at risk for developing other infections that are bacterial, fungal, or viral infections. Malignancies, so increased risk of skin cancers has been reported, but are there other risks? We'll talk a little bit more about that. Hypersensitivity reactions, so again, like allergic reactions. Immunizations, this is kind of true for all of the biologics, but all the age-appropriate vaccines should be given prior to starting these medications, and no live vaccines can be given while on these medications. Modified or killed vaccines can still be given, but not live vaccines. And then what we call non-infectious pneumonia, so other inflammatory causes of inflammation in the lungs that aren't from an infection. So this is what I wanted to mention briefly. Now, I will say this study is specifically about adults and is not for pediatrics, but it's some of the data that we have as of now. But as always, we need more information, more data about pediatric patients specifically. But this was a big review study that looked into the dermatology literature, the rheumatology literature, and the gastroenterology literature. And those are some of the specialists that most commonly use biologic medications for a variety of reasons. And they wanted to look at what is the risk of malignancy or cancer in psoriasis or with its treatments. So both psoriasis and some of its treatments have been associated with increased malignancy risk. But this study really showed that there was not much evidence to suggest an increased risk of tumors or lymphoma from, say, the TNF inhibitors specifically, other than skin cancers. So suppressing your immune system does still seem to increase your risk of skin cancer, and sun protection is really important when on these medications. So again, we need a lot more data about this long term. We definitely need a lot more data about it in pediatric patients, but that's one of the most up-to-date reviews that I was able to find on this. And then this is more specific for pediatric psoriasis. And this study looked at, So this study looked at like the relative risk and patterns of use of systemic medications for pediatric patients that have moderate to severe psoriasis. So that could have been patients that were using methotrexate, biologics, mostly etanercept for this study, cyclosporin, and acitretin, which is one of those retinoid medications. And the main conclusion that they found was that medication-related adverse events, this is what AE stands for, occur less often with the tumor necrosis factor inhibitors, so Enbrel, than with methotrexate. With the most common side effect of methotrexate being GI problems, so nausea, vomiting, upset stomach. Folic acid, which is a vitamin that's given when you're taking methotrexate, up to 6 or 7 times a week, does help with those side effects more so than just giving it once a week. But again, we need more information about patients on these medications for long term and what risks there are. So how do we decide which medications to use? And I've talked about all the potential side effects that can sometimes be scary, but not treating psoriasis can also be a real problem, and it's really important to weigh those risks and benefits of treatment versus not treating, or how to treat it. And how do you decide on the right therapy? Well, it's always going to be a discussion between you, whether it's yourself as the patient, your child as the patient, and your physician, and it should really be a team approach to understanding all of these things together to pick the best medication. From our perspective, the things that we think about are, what is the primary morphology? What does it look like going through all those different things that we talked about and ways it can present, and where on the body is involved? How fast is this progressing? Is it going from a couple spots to just everywhere within weeks? How old is the patient? Are they male or female, which really only matters for one medication, the acitretin, which can cause birth defects if a female gets pregnant while taking it. Comorbidities and level of disability. So what other problems do they have? How much is it affecting their social life? Are they having problems with bullying? Are they depressed, either just as a comorbidity or because they're really stressed about their psoriasis? And then the patient and family preferences. How feasible are these treatments and how expensive are they? And then if there are any kind of specialized underlying genetic variants that have been notified, there might be more specific medications for them. Usually this testing is not done unless it's very severe cases, and that's out of the scope of today's talk. So again, really weighing the risks and benefits of the therapy versus the risks and benefits of undertreated or untreated psoriasis. So the last thing I wanted to mention as far as treatment goes, so we've talked about the new approved medications, we've talked about long-standing medications that aren't necessarily approved but are still used regularly. And if those aren't options or have been exhausted and not working, clinical trials may or may not be an option for you. And I wanted to make sure you guys were aware of this website in ways that you can find trials that might be appropriate for you or your child. So this website is called clinicaltrials.gov. It's all one word, clinicaltrials.gov. And when you go to the website, there's a search area. So at the top, you can click a button that says recruiting and not yet recruiting. So that will limit more to active or soon to be active studies as opposed to those that might have been open and are now closed. In the search terms, you can type in psoriasis or a psoriasis related terms, so psoriatic arthritis, whichever term you're looking for. And then below that, there's an other terms box. You can add pediatric specifically. And then you can enter location information. So where are you in the country that might have a trial near you. So this, being aware of these things can then help you discuss them with your physician and see if these might be options, if some of the other options are not possible as well. So comorbidities, again, I mentioned we were going to talk about this. So comorbidities, as I said before, are other medical problems that can be seen in association with psoriasis. So commonly arthritis, also known as psoriatic arthritis, uveitis, which is only seen in patients that have psoriatic arthritis as a rule. Obesity, which likely has a bidirectional association, meaning obesity and potentially the systemic inflammation that can be around because of the extra fat tissue can then drive psoriasis, and then the inflammation from psoriasis can also lead back to obesity as well, and we'll go through a little graphic about that in just a moment. Other components of the metabolic syndrome, so high blood pressure, dyslipidemia, so high cholesterol, high triglycerides, diabetes, fatty liver, cardiovascular disease, and we'll talk about this psoriatic march in just a moment. Psychiatric disorders, so depression, anxiety, bipolar disorder as well, impaired quality of life for both the patients and the caregivers, and then inflammatory bowel disease, especially Crohn's disease, and that may reflect a common genetic background or predisposition as well. So psoriatic arthritis, the peak age of onset in children is 9 to 12 years. This can be inflammation of an entire digit or finger, sometimes called a sausage digit, where the whole thing will just look swollen and red and inflamed, or there can be inflammation of the tendons and ligaments, which insert into the bones. There's poor correlation with the severity of skin disease and development of psoriatic arthritis, but nail dystrophy or nail involvement may mark an increased risk of developing psoriatic arthritis. So the psoriatic march, this is that kind of conceptual framework to help us understand how the downstream impact of psoriasis and obesity can affect cardiovascular health. So psoriasis leads to our systemic inflammation that can lead to insulin resistance, and insulin is a hormone that is involved in blood sugar regulation. This can then lead to endothelial dysfunction. So the endothelial cells are the cells that line your blood vessels. And if those aren't functioning normally, then the blood doesn't move through there as well. And then that can lead to atherosclerosis, which most people have heard of as plaque buildup, and ultimately myocardial infarction, which is a heart attack. So are those things happening in children? Well, most kids are not having heart attacks, but they are kind of going through this inflammation process that then puts them at greater increased risk for these things to happen in their adult lives. And then as you see here, the obesity is leading back and driving the psoriasis and the systemic inflammation that then goes down this march as well. And these things loop back. The keratinocytes are the skin cells, and the more they proliferate, the thicker the plaques will be. And that's what we see as the skin lesions in psoriasis. And so these are the screening recommendations for monitoring for these comorbidities in patients. And a lot of them are sort of the basic screening recommendations of the American Academy of Pediatrics. They do have more specific involvement of screening for arthritis as well as depression and anxiety. So I won't go through every one of these, but as we mentioned, obesity, so checking your body mass index, even starting at as early as age 2. So that is a calculation that has to do with your weight and your height. Type 2 diabetes can be screened with fasting glucose, and when they do that depends on if you're overweight versus obese, and what other risk factors you have. Dyslipidemia, so again, looking at your lipid panel, your cholesterol, your triglycerides, so usually starts between 9 and 11 years, but additional screening might be recommended if you have other cardiovascular risk factors. High blood pressure, screening starting as early as age 3. Non-alcoholic fatty liver disease, again, ALT is a marker of the liver inflammation, and that can start at age 9 to 11. But again, some of these things are when to do them and how often. It depends on your other risk factors as well. Polycystic ovary syndrome can be associated, but only needs screening if there are symptoms or signs present. Gastrointestinal disease, so having any problems with abdominal pain, blood in the stool, bloating, gas, things that are pretty chronic would warrant gastrointestinal evaluation for signs of inflammatory bowel disease or celiac disease. Psoriatic arthritis should be questioned about any sort of swelling, pain of the joints, difficulty moving at all of the regular exams, and if any symptoms have developed, having specialized rheumatologic care as well. Uveitis, that inflammation in the eye, sending people to ophthalmology if they have any signs or symptoms or if they have psoriatic arthritis. Mood disorders and substance abuse, so yearly screening for depression and anxiety, and then yearly screening for substance abuse beginning as early as 11 years of age. And then quality of life is very important to ask about, how it's affecting children at home, at school, and their social lives, and just knowing that this can be such a big impact on them overall, and that it's really important to talk about it and address these issues and help them manage it. So this was just a review of our learning objectives. I hope that we have addressed all of these things. I will now move into the Q&A portion. We did receive a few questions ahead of time that I wanted to touch base on, and then I'm sure other questions have come in as we've spoken. So the number one question that we got was about food, diet and food allergies and psoriasis. So I'm only going to just mention this really briefly, but I will say that there is going to be a webinar about this particular paper, actually. I think it's next week. So if you have a lot of interest in the diet and food allergies, please sign up for that and you will get a lot more detailed information about it. But briefly, this is a study, a review study that looked at dietary recommendations for adult patients with psoriasis and psoriatic arthritis. Again, this is in adults, not pediatrician or pediatric patients, but it is a starting point. So what were the key things that they found? So in this review, they did find that the strongest evidence of dietary, there is strong evidence for decreasing weight with what they call a hypocaloric diet, meaning you're taking in fewer calories than your body needs on a daily basis. In patients that are overweight and obese with psoriasis can really help improve psoriasis. And this is all in combination with their normal medical management as well. So it's, again, that multimodal therapy. So that is something that when patients ask me about that in my clinics, it's the most important thing that I mention is if the patient is overweight and obese, is to talk about that, talk about ways that they can modify their diet and try to get into a normal, healthy weight range. The other thing that comes up a lot is gluten-free diets. So there is an association with increased risk of celiac disease in patients with psoriasis, but true celiac disease is quite rare and is only diagnosed by the presence of specific findings on a biopsy of the gut. So that's true celiac disease. But there's also gluten sensitivity. And that is when you have markers in your blood that suggest that you might have a sensitivity or allergy to gluten. When patients have one of these things, a gluten-free diet can be helpful for them. If they do not have one of those things, it hasn't been shown that a gluten-free diet will be helpful for their psoriasis. And then vitamin D and other specific foods and nutrients don't have as much evidence for that. So I really encourage anybody that's interested in this to attend this webinar and learn more about the diet association. But I wanted to at least mention that briefly with all the questions that came in from that. And then some of the other questions, what to do about the itch with psoriasis. So itch is not a problem for every patient with psoriasis, but it can be, and it can be a very severe problem. So the most important thing is making sure that the psoriasis itself is treated appropriately. So if patients have continued ongoing itch, a lot of times that means that their psoriasis is not being treated aggressively enough. But in addition to that, sometimes other medications like antihistamines can just help calm the itch or help patients sleep if the itch is a problem at night. Can psoriasis ever be in remission was a question that came in. So yes, when patients are on appropriate treatment, their skin can clear or be near clear. And I would consider that being quote unquote in remission. Does that mean that they're not susceptible to flares? No, they could still flare again, but the appropriate treatments can definitely help clear or nearly clear skin. And then another question was about what resources there are to help educate children about their disease and the treatments available. So a couple things to mention. One was just an article I found on the National Psoriasis Foundation website about raising children with psoriasis that can thrive. And I think it's worth looking at the article and just reading through it. It's just well written about some tips and a variety of psoriasis experts that mention things that they find helpful. But also the National Psoriasis Foundation has part of their website is called RSpot, and this is tailored to families and kids with psoriasis and has a lot of helpful resources there to work through this with your child as well. So I think that was all the pre-submitted questions. So I'll open up to other questions that might have come in.
Great, thanks so much. We did have a couple questions come in here. One, my child's psoriasis exploded at puberty. Is there a correlation between hormones and psoriasis?
Good question. I have seen that a couple times where that happens. Whether it's truly hormones, I don't know, but there could be a variety of things that could be triggering that. So just overall stress or other changes, but I do see it sometimes worsen around that time. So I don't know that we truly have the data on the hormone specifically. I'd have to look back and see, and I'd be happy to send that out if I do find anything. But I do see that happening sometimes, but it might just be one of these triggers again for patients that might not be true for all patients, but for some.
Great, thank you. Another person's curious about the long-term effects of pediatric use of methotrexate.
Yeah, so methotrexate, the main side effect that we see when kids are on it is stomach upset. So they can feel a little bit nauseous, they can maybe have some vomiting, they might feel a little fatigued as well. And this tends to be around the day or two that they take the medication. And the medicine's only taken once a week. Long term, I think that overall with methotrexate, one of the biggest concerns is about liver toxicity, so that the liver enzymes will be monitored while your child's on psoriasis. And usually once they reach sort of a maximum point, they're not supposed to be on the medication anymore to prevent that risk. And then I mentioned that safety of systemic agents for the treatment of psoriasis. They, again, talk about the methotrexate and the GI side effects mostly, but I don't know that we really have a true great study on the overall really long-term effects of methotrexate specifically. But it is in this category of immunosuppressing medications and needing more information about the potential risks of other, what am I trying to say, malignancies. I don't think we have any evidence to suggest that there are, but I don't know that we have enough evidence for it either.
Great, thank you. Next question here. What's the best treatment for a pediatric patient with erythrodermic psoriasis?
So I think that really depends on what options are available to the patient, either through insurance, but some of the things that are most commonly used in erythrodermic psoriasis, so cyclosporin is one of the most fast-acting medications that we have as far as an immunosuppressing medication, and that's usually the goal when someone's erythrodermic, is to get things under control as quickly as possible. So cyclosporin might be something that your doctor would recommend. And then depending on the age of the child or what other options are available, some of these other biologic medications can work pretty well as pretty quickly as well. So ustekinumab or Stelara could be an option if they're an older child, but those are some of the ones that we use most readily. But avoiding prednisone is something that I do like to mention when possible. A lot of patients have been given prednisone or oral steroids for their psoriasis, and although it might help initially really calm things down, as they come off of the steroids, it can really make their psoriasis worse. So we do try to avoid oral steroids.
Great, thank you. And then we have one more question here. Is there a maximum amount of time that a pediatric patient can be on a biologic medication?
Good question. I don't think that there is a set time on it yet. A lot of adults that have been on these for a long time are sometimes on these medications for decades even, and eventually either if they stop working, they might have to change to another medicine. So there is not a set time that a patient can be on it. I think it really has to do with how well they're tolerating it and if it's still working for them.
Great. Well, thank you so much for sharing your expertise with us. And if you have other questions, please contact our Patient Navigation Center by phone, email, live chat, or Skype. And once you leave today's webinar, you will receive a survey on the presentation. We'd appreciate if you can complete that and provide your feedback. And some of you have asked about resources for families and youth with psoriatic disease, and we have recently launched our spot on psoriasis.org, so you can check that out for stories and ways to get involved, as well as information for parents, teens, and kids. Finally, I just want to mention that a recording of today's presentation will be available shortly on our website, and you can access our complete webcast archive by visiting psoriasis.org/webcast. Thank you, everyone, for joining us, and we hope you have a lovely rest of your day.
Thank you.